challenges in California is that we have such an incredibly, and people say this all the time, but it's so true, such an incredibly diverse population. One of the things that we've worked on a lot in the behavioral health side over the last couple of years with the fortunate use of the Mental Health Services Act is trying to understand how to reach populations that have very different ideas of what mental health or addictions mean within the context of their culture. And one of the things that I learned when we were trying to do some translations is that some languages don't even have a word for mental illness. So that was a light bulb going off, and then trying to figure out, so how do they think about these behaviors? What does that mean, and what do we do about it? And this panel is going to talk about that. I'm going to introduce the panel briefly and then turn it over to you all. So first we're going to hear from Dr. Suzie Dong Matsuda. She joined the LA Care Health Plan as the Clinical Director for Behavioral Health Services in February 2014. Pretty new. And prior to joining LA Care, she worked for Orange County Healthcare Agency Behavioral Health Services for almost 20 years, and working with people living with severe and persistent mental illness. She was the Orange County Multicultural Development Program Coordinator after 7 years serving as a mental health clinic service chief. She completed her PsyD in clinical psychology from the Chicago School of Professional Psychology and her MSW from CSU Long Beach, and is licensed as an LCSW. Then we're going to hear from Debbie Innes-Gomberg, who you just heard from the audience. Dr. Innes-Gomberg received her PhD from CSPP in LA in 1992 and began work for the Los Angeles County Department of Mental Health that same year as a clinical psychologist. And one of the things I will say about what they're doing in LA, which is very interesting, they've really pinpointed several of the very specific cultural groups that live within their county and tried to develop services that would actually impact those populations. And what Debbie's going to be sharing, I think, is information about the outcomes that they've gotten from those projects. And she has with her Mariko Kahn, who's the Executive Director of Pacific Asian Counseling Services. Mariko Kahn has a wealth of knowledge and experience working with diverse Asian Pacific Islander communities. She got her Bachelor of Science in Cultural Anthropology from the University of California, Riverside, and an MA in Clinical Psychology from Antioch University. So we're going to hear from her, I think, a little bit about what that project means to her. And then last, but absolutely not least, we're going to hear from Ellen An, who is the Director of Korean Community Services. It's a nonprofit organization in Buena Park that offers behavioral health, public health, and social services to Korean immigrants and other populations in need as well. She's worked with a lot of groups. She's actually on our board as well, and I'm grateful to have her because she certainly brings a wealth of knowledge. With that, I'm going to turn it over to you all, and we'll be really interested in what you have to say.
All right. Again, I from the health plan, LA Care Health Plan, one of the largest health plans in the nation. We are serving the low-income Medicare folks. And I'm going to give you a picture of what it is we're trying to do in terms of integrated care and providing services, whole person care for our members. And then from that context, I will be talking about the shortage of the healthcare workforce, and going into the diversity of the workforce and the shortage and issues there. So at the current time, we are trying to promote what we call as care coordination for integrated care from the physical side and the behavioral health side. As you are all aware, there are different levels of behavioral health risk. We have mild to moderate to we call high, severe. And then we also have members who have both, whether low, moderate, or high on the physical health side. And so we're trying to do this integrated care where we coordinate care both for physical and behavioral health. For behavioral health, we have folks that they need non-specialty mental health, which is for low to moderate, and then we have the specialty mental health where they have a severe high needs behavioral health risk. And those folks, some may just have behavioral health condition, many have also physical health conditions. So with that, so we have to work with the doctors, the physicians, and as you know, in health plan, we are asking the physicians to, with the state recommendation is not a mandatory requirement yet, but with the state recommendation is to implement expert, that's called screening brief intervention and referral to treatment for alcohol use, and then also depression screening and also mental health screening to identify members who see the physician firsthand and having them, asking them to recommend them to do these so we can identify folks that need mental health services or substance use services that we can be referred to. And so from the health plan perspective, we truly try to push that forward. And then, as you know, many physicians with their times and everything else on their plate, it has been a challenge. And the other piece, the other thing is we wanted to, I'm so glad to talk, to hear about what they call transition of care or care coordination, moving not just the outpatient setting, but also from the inpatient setting to the outpatient setting, and making sure that, after discharge, that the members getting help from the outpatient timely, and that the rate of rehospitalization within 30 days or 7 days will be low. At the national level, national rate is about 15%, and we try to, aim for that rate and even lower, so we're making sure that our members are safely served. So those are the contexts where we're talking about whole person care and integrated care, coordination, and we need so much folks to be able to have behavioral health expertise, and also folks who with physical knowledge and skill that working together. And so talking about the workforce, then due to the fact that there is the projected increase dramatically of the healthcare workforce need because of aging, growth, diversity, there's much impact on primary care physicians, on mental health professionals, on specialty cares, and even other, we call allied health professionals, like lab, scientists and laboratory scientists and pharmacy technicians and all that. So those are huge shortage. And as you know, 4.7 million in California will be eligible for health insurance. And so we are looking at providing services with integrated care model, whole person care to the folks that are coming in. And as you know now, for 2012, the primary care workforce, the physicians, right now for 2012 for California is about 45,000, but additional needed for 2030 is over over 8,000, and for Affordable Care Act alone by 2030, the additional needs is 894. So right now, even the the nurse shortage on the physical health side for 2012 is about 193,000. We needed more, and we're not ranking for as far as shortage go. The lowest supply is about in the ranking of 50, and we are at the 45th ranking. So it's a huge shortage of nurses. And then also for physicians, right now we are in the 37th ranking as far as the low supply. 1 is the largest supply, and 50 is the lowest supply, and we are at the 37th ranking. And so the current population compositions of all on the physical side, as you see, right now Latino in California about 37% of the populations, but nurses is about 5%, and the Latino makeup, and physicians about 5%. and the dentist about 7%. And that's for, and for Asian Pacific Islander, the population is in California 12%, nurses 27%, physician 21%, and dentists is 32%. African American 6% in California, the nurses about 4% make up total of the nurses, the physician 3%, and dentists 3%. For Caucasian, though, 42% in California, and 59% for nurses. That 53% physician and 57% dentist. So that is to give you the gap in terms of the health workforce compared to the population that we have here in California. And so at this time, in 2009, the study conducted by the Center for Health Professions is acknowledged a number of the high vacancy rates for child psychiatrists, for community-based counselors, and psychiatric nurse practitioners. And in September 2011, the study of mental health shortage by the Office of the Statewide Health Planning and Development, it's recognized as the huge shortage across many rural areas for mental health professionals. And again, the California Employment Development and Department have clearly indicated that there's a huge demand for substance abuse social workers, and also substance abuse and behavioral health disorders counselors. So at this time, the California Workforce Development Council has been focusing on looking at increase the workforce of the following professions: primary care physicians, advanced practice nurses and registered nurses, clinical laboratory scientists, social workers, community health workers, promotorists, medical assistants, public health workers, and alcohol and other drug counselors. So those are the huge shortages. The recommendation, we have the slideshow, but I just give a summary in a nutshell. I know I have just 10 minutes, but just want to give you the overall picture. And so the recommendation for, we're talking about gap analysis to identify immediate opportunity to enhance workforce. We are talking about building capacity for department, institution, and agencies that involve the collection and reporting of health workforce and education data, so we know, like, it's kind of inventory to see what we have existing and what need to be developing more. And the other piece, I think this is more important piece, is, given that the overall workforce, there's a huge shortage, but having the workforce provider is culturally competent is even more challenging. And so there are other areas to consider is to increase the ethnic individuals, providers. And again, this do not equal to the increased language capabilities. As you know, for even the ethnic individual provider for the second or third generation of ethnic groups, immigrants or refugees, it do not mean that they have the same language capacity. Many of them may just English only speaking. And then the other to consider is to increase training in cultural competency in parallel with language courses. The other piece is a special attention to substance use treatment provider workforce. And then for ethnic communities, the issues of substance use, having enough providers in this area is a huge shortage. And early career interest building, and the other area is peers in recovery as a viable workforce, including peers in the workforce, and really not only just preparing them, but also provide opportunities for them to becoming viable workforce and in collaboratively in a team with other health professionals, and really truly integrated their lived experience and skills to be part of the workforce. And so at LA Care, we are trying to recruit diverse health professional both on physical and behavioral health side. We're posting position on Career Builder, on Indeed.com. We're posting, try to increase the diversity of providers to help the members in LA County. posting positions on diversity site, on Women's Forum, US Diversity, on blackboard.com, Job Access. We try to reach out to LA County workforce programs and job developers and job fair, and reach out to multimedia sources just to try to find diverse providers that they can be serving as I just shared with you, the integrated care model that we are inspired to. And thank you.
We only have 10 minutes.
Alice, do you happen to have my slides?
So there's
Glitch?
Little clicker?
yeah, a little clicker.
Okay. Okay. This one? Oh, there we go. Okay. All right, excellent. Good morning, everyone. I'm going to be talking about the LA County Department of Mental Health Innovation Project, which is on the integration of health, mental health, and substance abuse. And let's see here. Okay. One of the things that we did, and I know most of you are familiar with the MHSA component of innovation, but they're time-limited learning laboratories, essentially. And our particular project, it was for 3 fiscal years. We're in the last fiscal year of 3 of the 4 models of integrated care. Our project was on the integration of health, mental health, and substance use. And in each of the models, the models differ from each other, and I'll tell you about that in a minute. Actually, you heard about the integrated mobile health team from Dave Pilon a moment ago, but basically it's about the integration of health, mental health, and substance abuse via the partnerships between federally qualified health centers, FQHCs, and mental health programs, and substance use disorder programs. And the results of these should then inform the public mental health system. And so, and if you want to fund them beyond that, you have to find alternative funding to be able to do that. So the program I'm going to focus on, or the model I'm going to focus on this morning, is on what we call the Integrated Services Management Model. And I wanted to introduce Myrtala Parada Ward here. You want to wave your hand? She is the manager of that particular model and has done a wonderful job in leading this model. The populations we serve that Sandra had referenced are the African American population, Native American population, Asian Pacific Islander population, and Mariko Kahn is going to be talking about the outreach and engagement strategies for that population in a moment, Latino population, and the Middle Eastern European population. And again, the services are FQHC and the Mental Health Center. And with this particular model, one of the most compelling parts of it is the emphasis on partnerships with non-traditional providers in the community that support outreach and engagement, as well as ongoing service provision. And you're going to see some very compelling data about how much outreach and engagement it takes to enroll one client. What I wanted to do very briefly is just talk about how we're evaluating this program. And if you were at the policy forum a year ago, you heard me talk a little bit about this, but I've got more data this year, so more compelling information. First of all, what we wanted to do was measure the level of service integration, and we used the integrated treatment tool out of Case Western Reserve University. And I'll show you some additional data on that in a moment. But we wanted to measure level of service integration. We wanted to measure health status, mental health status, substance use, client satisfaction, community satisfaction, self-stigma, cost effectiveness, and a post-outcome survey for a sampling of our clients. So it's a pretty robust evaluation. This is an overview, and you can just take a look at it when you get a chance, of the measures that are completed by clients. So we have measures completed by clients and measures completed by clinicians, and then we have physical health indicators like BMI, A1C level, and what am I missing? We'll get, no, I'll get to it in a minute. And so the client level measures we have, and you can see the number of items up on the screen, the frequency with which they're collected, either quarterly or twice a year, and then the goals that are addressed in this. So the PROMIS Global Health Scale, PROMIS Alcohol and Substance Use Disorders Scale, the Physical and Behavioral Health Survey, client satisfaction, the post-outcome survey. I'm going to go through these pretty quickly. The clinician measures are fewer, and they have physical health indicators, illness management recovery, milestones of recovery scale, and the staff satisfaction questionnaire. What I wanted to do was break out the integrated treatment tool. There are 3 domains to this particular tool, and I wanted to give you a sense of where the different models scored. And I have to tell you, this data is about a year old. About 6 months or so into the project, USC, which partnered with UC San Diego to do our evaluation, met with each of the provider organizations associated with innovation, spent pretty much close to a full day interviewing, looking through charts to get this information. So, and the intention is to do it in a slightly less labor-intensive way as in the last year of the project. But what I wanted to show you, and is there a way to, pointer, perfect, okay, there we go. So what you're seeing here, this is the integrated mobile health team model that Dave talked about, the integrated clinic model, which is very similar to what Matthew described, I think, and then the integrated services management model, which is what we'll be talking about. What you see, the kind of the lightest bar, the top one, is the organizational domain. The next is the treatment domain, and finally care coordination domain. And so what you see here is the average scores by model. And what's interesting is that ISM and this is just beginning, on the way, and fully integrated in terms of the scale. And so ISM, in some respects, was in the just beginning phase, but for, I think, very, very good reasons. And I think this is really important as we develop our provider networks, particularly networks where non-traditional organizations and community-based organizations that haven't been part of mental health start to come together. It's really critical to be able to help and support them at this stage of the process. So what I'm going to do is go to the next one. This is the organizational domain, and it's by model. And I'm going to refer to some notes here. Let's see here. What you see here is with the ISM model, and again, it's that last one there, the multi-dimensional or multidisciplinary approach is pretty high with ISM, as well as the care manager. They were doing very, very well with regard to that when you compare them to the other 2 models. So that's the organizational domain, and what I should point out is these are all the elements of the organizational domain, and I know that it's hard to read, but you'll have that on your slides. The treatment domain, similarly here. Let me read this here. Again, you've got your ISM model here doing pretty well with outreach, which you would expect, and you'll hear more about that from Mariko. And then involvement of social support, again, very important to the model. And things like stepped care, integrated care planning. So that's the second part of that. And then third is care coordination. And so what you see here with regard to the ISM is this is lab and test tracking, referral, appointment reminders, medication reconciliation, and all of that. So you kind of get a sense, and I think assessing effectiveness and quality they started off very, very well on. So now I'm just going to go through mental and physical symptom reduction. And so what you see here, what you see here is mental health, and when the numbers go down, that is indicative of recovery. And so with mental health, what you have here is assessment 1 versus 3, and then assessment 1 versus 5, and they're all matched pairs that I'm presenting, and they're significant in terms of the reductions. So with mental health, people are starting off here and then going down to about here in terms of the ratings, 3.45 to a 3.85, from a 3.85 to 3.45. And then with physical health, similar but not quite as dramatic reductions. But again, that's indicative of better health and better mental health. Symptom reductions on the illness management recovery scale, which is a wonderful scale if if you're not familiar with it. Again, reductions indicates overall improvement. And in terms of the overall ISM, these are the sorts of reductions you're seeing. Assessment 1, which is baseline, to assessment 3, and then assessment 1 to 5. And then you look at the API, Asian Pacific Islander, and you see even more dramatic reductions. In fact, I think the API on the IMR, I know a lot of acronyms, they're actually performing the best on that in terms of looking at match pairs. So you see 3.31 to 2.46. I'm going to go through these quickly because I know I don't have a lot of time. The Milestones of Recovery Scale, again, that's a 8-stage rating going from extreme risk to advanced recovery. Here are your baseline scores. And at baseline, when you look at all clients, in this case 1,226, the majority of them fall into the ratings of 5, poorly coping but engaged. When you looked at matched samples, either the assessment 1 to 3 or 1 to 5, then you start to see the advancement in recovery. So you go from, in this case, 53% poorly coping and engaged to 40%, so only 36% in that category, and 40% in the coping and rehabilitating, 9.6% in early recovery. When you look at assessment 1 versus 5, so people that have been in the program longer, that 48% becomes 29%, and then in more 6, about a 39%, more 7, 16.5% almost, or a little more, and then in terms of Moore's score 8, 4.4%. So you're seeing with Moore's scores a dramatic improvement. Substance use reductions, this is always a hard one because when people come into the program, they're not always necessarily admitting that they use substances. They get to know you a little bit more and they may be a little bit more forthcoming, but we're still seeing some reductions. Again, so lower scores means a reduction. And then what you see here is during the last 6 months, how often did you have any kind of drink containing alcohol, such as beer, wine, or liquor? And you see assessment 1 versus 3, 1 versus 5, the nevers, and then every day. And there's some reductions in the everyday and 4 or more times a week category. Internalized self-stigma is a 10 or 11 item questionnaire. And what you're seeing here is reductions over time in your perceived feeling that mental illness is a problem and you shouldn't admit it and you shouldn't work on it, for example. Oops. And then increase in community involvement. I think this is really important because this really speaks to the heart of flow that Dave was talking a little bit ago. And so this is the percent of people that have paid employment at baseline, at assessment 1 through 3, and then 1 versus 5. And so the asterisk indicates statistically significant improvement. So for example, with paid employment, an assessment 1 versus 3, people in the ISM program went from about 27% to about 32%. And then 1 versus 5 went from 28% to 33.5%. Then going down to attending school, the clients in assessment 1 versus 3, 15.5% initially to 19.1% in school, and that was statistically significant. So that is just, I want to save time because Mariko is going to really talk to you about all the work that has been done around outreach and engagement that will really inform, I think, our services going forward in very significant ways, particularly around the health neighborhoods that Dr. Southard talked about yesterday. So I'm going to, there we go. And do you know how to get your slides up?
No.
Okay. Alice, how does Mariko get her slides up? Oh, it just keeps going.
Oh, okay. Because I'm one of those few Asians that's technologically challenged. Good morning. My name is Mariko Kahn, and I'm the Executive Director of Pacific Asian Counseling Services. And we provide mental health services in 8 different Asian Pacific Islander languages. So we're very multicultural within the Asian population, but we also serve Spanish and African American. I think it's important to reflect that in order to change the present, we have to understand the past, our traditions, and apply it to the future. So when I was planning this talk, I wanted to point out that the Western concept of integrated care now, as we've been discussing it, is oftentimes reduced to a shared client chart and providing medical and behavioral health services. But in our communities, we consider that well-being comes from harmony, harmony within and harmony without. And when we talk about a well person, we're talking about a person who has balance. Balance among the mind, the soul, and the body. So it's not separate. We don't have these elements just floating around. So when we look to provide integrated care to our APIs, we needed to help them with their emotional, physical, and spiritual problems. So today I'm going to present a little bit about the outreach and engagement we did, and the information that I'm presenting is based on 4 different API ISMs: the Cambodian, which was my group, the Korean, the Chinese, and the Samoan. And so, yay, okay. So a lot of you know this data. The data are showing, of course, the rapid growth of APIs in Los Angeles. And what's of interest, and this was pointed out in the work shortage presentation by Suzie, is that there are apparently approximately 30 different API ethnic groups, and that about 530,000 of them are limited English proficiency. So when you consider how large that population is and what we need to do in order to outreach to them, language obviously is going to be one of the biggest barriers to access. So in my Cambodian study, of our clients, 50% are monolingual, 18% are limited English, and of that group, of all of them, 50% are illiterate in their own language and illiterate in English. So, you know, when you do a survey, somebody has to sit there and read it to them. It's not just, here, fill it out. When we look at the health status, we find that the leading causes of death are what you might expect: cancer, heart disease, and strokes. I forgot to, see, told you I was challenged. And diabetes, hypertension, obesity. But what is interesting is to find that so many of our APIs are less likely than other ethnic groups to have health insurance, and that oftentimes has to do with the undocumented. So as we look at the population, one thing that sticks out in my mind constantly is that in LA County, we're 16% of the population, and yet our utilization rates are closer to 2 to 3%. And it is an ongoing struggle to figure out why. But one of the things that we've been learning in our ISMs is that the stigma is so tremendous that it is very difficult to overcome. When you have a culture where shame is a prevalent reaction, and there's a need to save face, then coming up with a diagnosis of mental illness is very, very difficult. We have alcohol abuse and gambling addiction, but a lot of it is considered okay in our cultures and is actually promoted in many of our families as activities. We also have symptoms that indicate to us that mental illness is interpreted by the family members as actually disharmony with our ancestors. And one example we had was one of our families was having a lot of problems, and it was because they felt that the ghosts of their families who were killed were still upset. So we actually had to do a ceremony so that they could properly, symbolically, bury their ancestors in the right way. I'm going to just skip ahead because I know we have time. We talked about the workforce shortage, and but what's very apparent to all of us is that there's an enormous lack of knowledge about illness, both for physical and behavioral illnesses. And when we went out, we found that many of our clients had not even had access to medical treatment. And to educate them about all these terms that are thrown at them took an enormous amount of time, as you can imagine. We also had to translate a lot of materials but we didn't realize how long it was going to take. I mean, we're still debating the right words to use because, as was pointed out earlier, mental illness is not necessarily a word that you can translate into Khmer, for example. So we had many, many interesting conversations about that. And then many of our populations come from areas where the government either treats mental illness as a way to put you into prison so that they can control you, or that there's a hidden agenda in many ways, and you're tortured. So trying to get them to come to get help from a government agency is very difficult. This next slide, I'm not going to spend a lot of time on it, but I think what it shows is the number of contacts we had to do in order to get what looks at first to be just a few clients. So with the Samoans, the Samoan group did 3,500 contacts. Now, some of them are festivals and church gatherings, but a lot of them, at least that I'm aware of, were one-on-one. So with my Cambodian group, we did 3,800 plus contacts, and we got 66 clients. Think about that. Almost 4,000 to get 66. It takes multiple engagements. So what are some of the strategies that we developed? And honestly, some of these are not so earth-shaking and surprising, but I think we get so caught up in trying to make sure that we get the numbers that we forget that we are dealing with people. So I'm going to just go through them very quickly. First, you have to understand your community. You have to understand their reasons for coming to this country, and many of them suffer from historical trauma. And that's something that can be dealt with actually at a community level. Secondly, it's very smart to understand the healing practices in those communities. We've been using spiritual ceremonies like the Buddhist blessing ceremony in order to outreach to our Buddhist clients, but also to get their family members to come and join in and partake. And from that, they feel like, wow, you understand me. It's not just language. You understand why this spiritual practice is important to me and why it heals me. I trust you. You have to have respect and patience. You have to hire staff that have respect and patience. So you have to hire people from the community. And we found that by hiring a minister, a Buddhist minister, the Koreans found by hiring a Christian minister that the outreach went more quickly and more efficiently because the spiritual leaders in the communities were willing to then trust you. We also, of course, use staff and peers who are from the community. Family. Family is much broader in our communities. It doesn't mean the nuclear family. And in the Samoan culture, it's more like a tree. It's huge. I can't tell you the number of times my Samoan staff have said to me, oh, I have to go to the funeral of my aunt or my uncle or my parent. And I was like, didn't you just go last month? And, no, this is a different one and I have to go. So you have to make that adjustment. And then, interestingly enough, when your staff gets connected to our clients or consumers, they start treating our staff like family. So we had to set all kinds of boundaries like, no, you can't have food, no, you can't give them gifts, and explain it in a way so that the person who's trying to give to you doesn't feel rejected. But they do eventually just say, you're part of my family. We always work to match the outreach and engagement to the client's style. So I think one of the most important things is for all of you to understand that you're going to have to do multiple engagements. And anybody who worked with homeless, no, it's not just one or two times. It's over and over and over again in many different ways. And it has been a little bit easier when there's been a medical condition because that's more acceptable in terms of psychosomatic disorders, but still, you have to go beyond that. And we have found that the branding of an illness is very off-putting to our clients. Nobody wants to be diagnosed with mental illness, but especially with our APIs, we found it's very difficult. So we try to use non-technical words. I'm sorry, I'm shivering because it's cold up here. We also use education as a tool. You know, I think many of you probably do the same things. We use classes instead of, come in and learn about domestic violence because no one would come. We try to create situations where the clients connect with one another because they're so socially isolated. Even though their families there, they don't want to talk about it. So when they actually can have an opportunity to talk to other consumers, they really connect in a very deep way. And then you take the intake process and you have to divide it up into transitional steps so that they can understand it, because they find it very intrusive and off-putting when you ask them questions that we as Westerners would say, oh, no big deal. They find it like, whoa, why are you asking those questions? So as I mentioned before, Asians' APIs strive for harmony and wholeness. The most important thing we learned was this: you cannot get your clients in unless they feel you're really helping them. You have to figure out what is their immediate needs. It might be housing, it might be transportation. Until you can prove to them that you can actually help them, they're not going to come from mental health services. So we are very fortunate that the funding allows us to do that. And for them, many of them want financial stability, so anything that helps them to get a job is very important. And so I would say that what we've learned is actually what we knew, but now we're proving it the Western way. And we've had a wonderful time doing it, and we hope that this kind of outreach and engagement will be continued. Thank you. Do I just leave it? Okay.
Hello, everyone. Can you hear me? When I was asked to come speak, I told the folks who asked me, I'm not really an expert in policy, and I don't, but I can tell you I'm an expert in the very local ethnic community I serve here in Orange County. And so I'm going to take you down to the very micro level, the client and community level, and just take you on a journey as to what my agency on our road to integrated care. And perhaps you can glean some insights from that. I'm going to start with two caveats. One is I am not an expert in the policy field, but I am a fierce advocate for my community, the community I'm embedded in, the Korean American community here in Orange County. And I make no bones about it. I believe firmly that every Korean American in Orange County needs access to the same services that everyone else has. And I will do whatever it takes as a community-based organization's leader to get there. And then the second caveat is I speak many languages, English and Korean, obviously, but beyond that, the language of managed care, immigration law, food bank services, transportation. I speak the language of whatever setting I'm in. And so that makes me a jack of all trades, but master of none. And so if I am not speaking at a certain level, I hope you understand. It's just by my very nature, I need to be an expert in many fields. So my agency's journey begins in the 1990s. We are a broad-based agency doing all those services, and behavioral health is a very specific, we see a need, but we don't really know how to get into it. But in the 1990s, the courts come asking. We have this influx of Asians, and we know you speak Korean. Can you help us? So we do. And we began our journey into court-mandated counseling services. And now we provide almost everything. Any behavioral health issue in the courts, we do, except the most serious crimes. And as we're servicing these clients, not just Koreans, but Koreans and all others, because contracts are structured not around the Korean community, but contracts are structured to the county's needs or whoever writes the contracts. As we're servicing court-mandated clients, we go, these folks need a lot more than what's mandated. And let's see what mental health resources are out there. And we find very little. And it's really frustrating. But we march on, like most agencies. And then we hear rumblings in the early 2000s about this thing called MHSA. And 2004 hits, MHSA passes, we attend a gajillion provider forums and things, and we gear up, and we get a few contracts, primarily PEI, and we have a small FSP program. So we're now a mental health provider. And we do our best to make sure that the services that the County of Orange provides under MHSA get out to the Asian communities. We can't do everything, but we do our best to do what we're contracted in. And we march along, and we do a needs assessment somewhere, and we realize Koreans have the highest uninsured rate in Orange County. And so I go knocking to all the community clinics, and I go, do you have any Korean staff? And I find none. We find none. And we go, where do all the Korean uninsured go? And we get no answers. And so we say, well, let's just open up a primary care clinic. How hard can it be? Little did I know. But we do. And in 2010, 2011, we become a primary care clinic. And we hope in a few years we'll become an FQHC. The journey has been a lot harder and a lot more complicated than I thought it would be, but we're here and we do primary care. And then I hear rumblings of ACA and behavioral health and psychiatric care. And doing MHSA work, I realized psychiatric care is a huge need, especially if you talk about the dearth of psychiatrists, add an ethnic component to it, and you find I can count on one hand the number of psychiatrists I can find who do community-based care in the Asian community. And they're hard to reach. And so we go, how hard can it be to provide psychiatric care? Because then we can control the appointments. And we hear all this stuff about ACA, and so we go knocking to our, Orange County as a one-plan managed care county. And we go knocking and we find out we can do it. So in 2014, we become behavioral health managed care, we joined the network, the IPA. We're learning all this new language. We're learning the world of capitated reimbursement. We used to just know contracts, but now we know capitated, we know managed care, we know IPAs, networks, all this new language. And like most providers, we know substance abuse is a huge issue, and we actually have some expertise because we did all that court-mandated work way back then. And we now have to do SBIRT because we're a primary care provider. And we go, then what? We do this SBIRT, and where do we send them to? And who reimburses us for that? And so we go knocking and we find out there is a way to get reimbursed through state drug Medi-Cal, a direct contract. So we go knocking. And as of 6 months ago, we're now a state drug Medi-Cal direct care provider. So once we do the SBIRT and we do a referral, we refer internally, and our outpatient substance abuse treatment program is up and running. So in essence, it's crude, it's not perfect, it has a lot of problems still, but we are a small ethnic CBO locally here in Orange County doing our best to provide substance abuse, psychiatric care, mental health care, MHSA work, and primary care on our road to FQHC work, and doing it as best as we can. And we did all this because we care about the community we serve. We will find a way. If we can dream, we find a way, and we're persistent. So we got here because we were completely driven by need. We're not driven by anything else. If we see a need in the community, we respond, and we find a way to get it done. And somehow that got us here to integrated care. And we're resourceful and persistent like all immigrants are. And we attend meetings and different things to learn. And every time we pick up information, we act on it. And that got us here. So with that said, there have been a ton of challenges, and these are challenges that most ethnic CBOs face. Well, the first challenge is it is so complex. I feel like our consumers and our clients most of the time, I can't imagine what it's like for them when it's, I have 2 graduate level degrees, and I am trying to figure it all out, and it's really hard. And we also, the other challenges, there are significant barriers that are beyond our control, and we just have to accept some of that. So that's one barrier. The second barrier is workforce shortages. I'm not going to go into that. You know, psychiatrists, my God, if we need one workforce area, we need psychiatric care and expansion of that. Yeah, especially child, Mariko is saying that. The third barrier, and this is a policy point. You know, policy tends to be made up here, and it's tailored towards state needs or county needs. But actually, the needs of communities are very, very local. They happen in 1,000, 5,000, 10,000 people increments. And so to have the best programs, and you know, this is my bias, you have to be responsive to very local needs. And so one of the challenges is taking these broad-based strokes, you know, let's do this in, you know, this county, and translating it to the local level, to the community that I serve. And that's a constant challenge for me every day. The next challenge is, you know, and these are challenges you probably are all very familiar with, and these are barriers beyond my control, actually. Drug Medi-Cal has its host of challenges, I'm sure you're aware. Behavioral health implementation at the managed care level can be rocky at times, and we are just floating along. These are challenges that I cannot control and I probably can't address today, but they're challenges. The fifth is, at least in my county, the primary care safety net is in crisis, and that's because of all the Medi-Cal enrollment. We've had our Medi-Cal enrollment went up from 400,000 countywide to 600,000. And with that significant increase, the community clinics are basically burdened with a lot of these patients. We're the last resort. We don't have a county-managed primary care system. And so the community clinics have to take this blow, basically, and it's a blow because Medi-Cal reimbursement is so low in a managed care context. And so primary care, just keeping our clinic alive is really, really tough most days. And then the last challenge is, and this is the big question mark, but it's huge in ethnic communities, is immigration. What are you going to do about the residual uninsured in the primary care environment? What's going to happen to the undocumented folks? Because now everyone's Medi-Cal. And then another issue is, okay, you do have Medi-Cal, but there's all these rumblings of, you know, if you're not a citizen and you're a permanent resident, and this is the bulk of our communities at least, what happens to your Medi-Cal coverage? It's a government benefit. Will it affect immigration status? And for most communities, immigration status comes first after medical care. And so this is huge if you find folks who aren't going to be covered under Medi-Cal because of immigration concerns. So that is a challenge. And then the final challenge is in most ethnic communities, the divides, mild to moderate, SPMI, they're pretty insignificant. You know, people just want help. They want help, and these are categories, constructs that are made at another level. And so for an agency like ours, we're constantly translating this down to that very basic client level. And that client may be SPMI, but we sure are going to help them. And that's a challenge because sometimes the folks above us don't really understand that. And then the last challenge that no one seemed to figure out, at least in the managed care context, is we need case management. You know, it's funded in MHSA, but in a managed care context, it's not. Or it's done at a network level. It's not done at a very basic local agency, clinic, whatever level. And until that gets solved, care will be incomplete, at least in my eyes. I want to take a little step back to the history. We do provide an innovation integrated care project in Orange County, similar to the ones the prior speakers spoke about. And actually, that was the impetus behind a lot of our thinking moving forward. So I want to sum up with a few thoughts about integration. First, for ethnic communities, everyone knows it, but I just think it needs to be said again. Integration is fabulous for ethnic communities. It's the first time we can actually dream comprehensive care at a very micro level. There's still a ton of work to be done, a lot of challenges. It's really rocky, but that light at the end of the tunnel is something that community-based workers like me dream about. It's better care, and it's whole person care for that person who walks in the door who can't enunciate their issues, but they come with a whole host of them. The second thought I wanted to summarize with is, for ethnic CBOs, integrated care is a couple years ago it started coming into our vernacular, and it was but for ethnic communities, it's always been done. The CBOs have always done integrated care. We don't have categories. You walk in here with problems and we help you, because we're mission driven, and we're driven by our mission to serve those in need and serve vulnerable populations. And so the challenge is to get ethnic CBOs who have always been doing this in one way or another to that level where they can work with the policymakers and the contract makers. The last and final thought is I see the light, but it's going to take a lot of commitment from a lot of you folks out there. Ethnic CBOs, including mine, we're still very crude. We're learning the language. We don't have, don't forget, we're jack of all trades, but master of none. So we may not be as sophisticated in some of our language, but we care about that whole person. We care about comprehensive care. So I'm pleading with all of you that you renew your commitment to ethnic CBOs and understand it will take sustained effort. But at the end of the end of the tunnel, it's really some amazing stuff that can be done. I'm just getting a taste of it now as I've implemented these projects, and it really is, it's quite amazing. We have someone walk in for food bank issues, and we just walk a few doors down, and we have a medical appointment for them, and then the psychiatrist is in today, let's talk to her. And what took weeks and a gajillion phone calls and a lot of closed doors now is being solved pretty easily by the team that works at my agency. It still has issues, but the sustained effort and the commitment by policymakers really will result in some amazing, amazing care at the very, very local level. So I hope that provides you some thoughts, at least from an ethnic CBO's perspective.
Just one fast question on the drug Medi-Cal services that you added. You mentioned that you're now a direct contractor with the state for that benefit. Can you explain why you're not contracted with the county for it?
We've never had an opportunity. We have several contracts, but not outpatient substance abuse treatment. And we've just never had an opportunity in our county for a lot of different reasons, not particularly anyone's fault. And so drug Medi-Cal direct contracting was the best way to do it. And I want to add that drug Medi-Cal direct contracting is actually better for ethnic communities because county contracting has a lot of, in general, a lot of steps that people, you got to meet this requirement and you got to meet that requirement and you got to meet this requirement. But in ethnic communities, a capitated reimbursement or fee-for-service reimbursement, at least in a medical environment, gives most agencies a lot more flexibility in who they can accept and who they can treat and how much they can treat. So in that way, we pursued that route. But if a county contract comes that will benefit the Korean community, we'll be there.
I bet you will.